All right, everybody, we're just about to get started. I wanted to check in and make sure everybody can see and hear me okay. Just want to get out any tech issues before we begin. Looks like everything is running okay. Welcome, everybody, to Free Webinar Wednesday with Archer Review. This is awesome. We are going to have such a fun hour. I'm Cait. I'm one of the tutors with Archer Review. Now, before we begin, I'll just introduce myself. My background is in the emergency room. I've also worked in ICU. I've done some travel nursing, but really my heart lives in the emergency department. I love the unpredictableness of it. I love being a bit of an investigator. I love things like case studies where, you get a patient coming in with a set of symptoms and we're not sure what's going on with the patient yet, and it's our job to figure it out. So we get to play a little bit of detective when we're working in the emergency room. Any future emerge nurses out there? Now, today we have our wonderful other tutors, Rachel and Jennifer, who will be available in the comment section if you guys are coming from Facebook or YouTube, or here in the question box if you guys are on GoToWebinar with me. Ask any questions that you need. They are wonderful and will be happy to help you. And if I ask any questions, that's where you're going to go. Or you can sit at home and answer it to yourself and see if you are correct. Now, I'm going to admit it, I love cardiac. I think the cardiac system is so cool and also incredibly important. A lot of the time in the emergency department, our job is to keep our patients alive. And it really comes down to the cardiac system. Because if that heart isn't pumping enough, if it doesn't have enough blood supply, if it is not strong enough, if that blood flow isn't flowing in the direction that it's supposed to be, all of that is going to affect the way that your patient's organs are going to receive oxygen. And ultimately, that's what keeps your patient alive. So I'm so interested in cardiac. I hope I will help you guys love it too. I know it can be a really challenging system to understand, which is why you guys are here today for Free Webinar Wednesday. Now, if you haven't had any webinars with Archer Review before, we love using a tool called Slido to help us, communicate with you guys, to keep these sessions interactive. Because the more that you guys participate and challenge your brains to answer the questions that we will ask, the more you are going to be able to reap the benefits from these free webinars and put that information in your brain where it will stay in your brain. So let's practice using Slido. You can either join Slido at slido.com and inputting our code there, cardiac AR. You can use the QR code to try and you can use the QR code to try to join. Either way, let me know where you guys are joining today via Slido. Are you guys able to join in with Slido here? Just wanted to see. Looks like we might not be able. Oh, there we go. Participants are typing now. Great. Just want to make sure this works. This is the tool we are going to use if we're going to ask questions, we're going to practice. Whoa, lots of Torontonians here. Awesome. Archer gets a lot of love from the US, and we are recently starting to get some love from Toronto, from Canada. I'm Canadian and I'm from Toronto, so I love to see my people here on all of our webinars. Colombia, very cool. New York, home, yes. Great. Mary Rose, if you're joining Slido, you can use slido.com, and then the code should be cardiac AR with a capital C and a capital AR. Ooh, lots of Philippines and New York. I'm just going to wait for a couple more answers to get in. And Slido's really awesome because then you guys can participate. I can see everybody's answers wherever you're coming in from. Pakistan, awesome, very cool. Albania, yes. And if you are on GoToWebinar, you're totally welcome to use that question box. I can see your answers there. Very cool. You're from Florida. I'm jealous. It's not too cold here so far, but I know the cold is coming and you guys will be staying warm. From the UK, Thailand, very cool. I'm going to be heading to Thailand very soon, actually. In Midlands, nice. Houston, I love it. Thanks, guys. So this is what we are going to be using throughout our case study today to figure out, what's going on with their patient. Let's challenge our brains. Let's use our critical thinking. Slido is going to help us achieve that. And again, if you have any questions about it, just message our friends in the chat box and they will help you. But keep in mind, using slido.com and our code cardiac AR will give you access to it. Oman, Nepal, so cool. I love seeing students from all over the world. It makes me really happy, and I just think it's really cool. I love traveling. So let's get down to it. You guys are here to learn some cardiac, so let's get into our cardiac system. And I could not start our cardiac lecture without talking about the blood flow through the heart. Now, the blood flow through the heart is the bread and butter of our cardiac content. It is so important for us to understand the blood flow through the heart. For you guys, do you find like heart failure challenging? Do you find those congenital heart defects challenging? If you do, if that is you and you get those questions and you're like, darn it, I just don't know, maybe you should brush up on the blood flow through the heart. I promise, if you understand the blood flow through the heart, it makes those concepts like heart failure and congenital heart defects a lot more clear. It makes a lot more sense. So let's get to it. When I think about the blood flow through the heart, I always think about the tissues first. You know how blood is going to flow to our tissues. Our tissues are going to use that blood. They're going to take the oxygen from the blood. They're also going to take all the nutrients like glucose from the blood and use that for energy. So those organs and those tissues can carry out their daily functions. Now, after that blood has been extracted of its oxygen, think about where it wants to go, right? So if our blood is deoxygenated, it wants to go back to the lungs in order to pick up more oxygen. Now, we don't have a direct pathway to go from our body to our lungs. So we always have to stop at the heart first, because the heart is our center of our circulatory system. It is the pump, and its job is to move blood around, which is why we always need to stop at the heart first. So from our body, we are going to go towards the heart. Are we going to be taking veins or arteries to go towards the heart? Think about that for a second. Are we taking veins or arteries to go towards the heart? We'll be taking veins, right? Veins go towards the heart. Arteries are away. They go away from the heart. So veins, their job is to go towards the heart. The two big veins that go towards the right side of the heart are called the vena cava. We have the superior vena cava and the inferior vena cava. These two veins will bring blood all the way from the rest of our body into our right atrium. And that's where we start off in the blood flow through the heart, from our veins into the right atrium. Now, in the right side of the heart, the right atria will move blood through the tricuspid valve. I always know the tricuspid valve is on the right side because tri is right. It squeezes the blood into the right ventricle. From the right ventricle, it'll move the blood through the pulmonary valve into the pulmonary artery, which will then take us to the lungs. So this whole right system functions at the same time, but independently from the left side of the heart. We take the veins into the right atrium, into the right ventricle, and we take the pulmonary artery into the lungs. Now remember, the pulmonary artery is an artery because we are going away from the heart. We're going away from the heart towards the lungs, so it is an artery. Now, in the lungs, gas exchange occurs, right? Those little alveoli are going to fill with oxygen and diffuse oxygen into our blood vessels. Now the blood becomes oxygenated. Once our blood becomes oxygenated, we're going to want to go back to the body, right? Because we want to be able to be used for those daily functions. Those cells need us, they need the oxygen. So we need to go back to our body. But of course, there's no direct pathway from the lungs to the body. We have to go through the heart first, the left side of the heart now. So we have oxygenated blood coming from the lungs. Are we taking a vein or an artery to go back towards the heart? Remember, if we're going towards the heart, we're taking a vein, and we're going to take the pulmonary vein now. Any vessel that goes directly towards or away from the lungs gets the name pulmonary attached to it. So we're taking the pulmonary vein into the left atrium. From the left atrium, the atrium will squeeze and move the blood through the mitral or bicuspid valve into the left ventricle. From the left ventricle, that will also squeeze the blood through the aorta. Now, is the aorta a vein or an artery? It is an artery. We are going to bring blood from the aorta away from the heart towards the tissues, and it will enter our arterial system to perfuse our cells and our organs. And that's how the blood flow through the heart works. We take deoxygenated blood from the body, move it via the veins into the heart, into the lungs. We get oxygenated. From the lungs, we take the veins towards the heart, move through the left side of the heart, and then away from the heart using the arteries to perfuse those cells again. That's how the blood flow through the heart works. Now, today we're going to go through a case study, and we are going to figure out what our patient is presenting with and how we are best going to treat the patient. Now, let's go through it. Does anybody have any questions about blood flow through the heart before we move on? No? All good? Okay, so let's get started. So, we are a nurse, you're a nurse, working in the emergency department, and you're admitting Mr. Brown, who walked into the ER with his wife. He's a 62-year-old male with a past medical history significant for type 2 diabetes, and he takes metformin daily for it. He also has a history of hypertension, which he takes an ACE inhibitor for, hyperlipidemia, he doesn't take any medication for that, and he currently smokes half a pack per day of cigarettes. He doesn't have any allergies, and he arrives with complaints of chest pain, shortness of breath on exertion, and nausea. Now we're going to use Slido. Tell me, what concerns you about this client? What are some findings that are concerning to you about Mr. Brown today? Shortness of breath, yes, Anna. Yeah, he's a smoker. He's complaining of chest pain. Shortness of breath is definitely going to be an alarming sign here. He's not taking medication for his hyperlipidemia. Yeah, he's a daily smoker. Shortness of breath, chest pain. Awesome. Yes, guys. Now, what I will tell you is for our patients on the NCLEX, if they are complaining of chest pain, shortness of breath, or dizziness and lightheadedness, I want you to be concerned about those patients. I always want you to be concerned about those patients experiencing those symptoms, because that tells me that the patient's cardiac output might be compromised. If we don't get enough blood flow to the heart, our patients will experience chest pain. If we don't get enough blood flow to our lungs, then our patients will experience shortness of breath. And if we're not getting enough blood flow to the brain, our patients will experience dizziness or lightheadedness. So if you see any of those symptoms on the NCLEX, I want you to be more concerned about those patients. And definitely all of those findings that you guys are mentioning are concerning. So let's talk to Mr. Brown a little bit more and explain and talk about this pain, explore it a bit. We'll ask him, have you had chest pain like this before? And he says, I used to, but only when I exercised. Now it's even when I'm sitting down. Tell me where the pain is exactly. Can you point to it? And he says, it's in my chest and left arm. On a scale of 1 to 10, how bad is it? I would rate it about a 6 out of 10. Now take a minute. Is this our subjective or objective assessment here? Go back to way back to first year nursing school. Is this our subjective or objective assessment? This is subjective, right? So we're exploring this pain, we're getting the information from the patient themselves, we're asking questions. That's our subjective assessment, and we are learning about Mr. Brown's pain. So it sounds like he has 6 out of 10 chest pain, and it goes to his left arm as well. It did not get relieved when he was sitting down. It's still having pain when he's sitting down. And at this point, we're going to move on to our objective assessment, where we do a head-to-toe assessment of this patient. Now, when I'm doing a head-to-toe assessment in the emergency room, I always make sure I go from head to toe, because developing a system for assessing your patients is really important as you become a new nurse, because it makes sure you don't miss any systems. So when I assess the neuro, I see that he's alert and oriented, he's feeling a bit anxious, and he's complaining of that 6 out of 10 chest pain. Sometimes we like to lump pain into neuro. Then we check respiratory, and he has tachypnea and diminished lung sounds. And we'll check cardiac, and he's hypertensive. You can hear S1 and S2 sounds. Those are our normal heart sounds. And you can feel radial and pedal pulses at 1+. Now think a minute, what does 1+ mean for our patient? Well, pulses get scored on a scale of 1 to 4+. 1+ means it's kind of weak and thready. 2+ is normal. 3 and 4 is more bounding. So at 1+, we're going to be a little bit concerned of this patient for sure. GI, abdomen is soft. His last bowel movement was yesterday. He's nauseous, but he hasn't vomited, and he has hypoactive bowel sounds. When we assess his GU system, he last urinated 1 hour ago before he arrived to the ED. And when you look at his skin, he has no open wounds, but he appears sweaty. What's the medical term for sweaty? It's diaphoretic, right? Diaphoretic or diaphoresis means that my patient is sweaty. Now, when we check his vitals, his heart rate is 110. His blood pressure is 176/82. It's pretty high. His sats are 89% on room air. His rest rate is 26, and his temperature is 37.9 Celsius. Now, tell me, we're going to join the quiz here. Great. We're going to use Slido just for this next question. I'll get a few of you guys to join in, and then we'll show you what the next question is. Awesome. Hey, everybody. Cool. So, based on your initial assessment, what findings require immediate follow-up? Select all that apply. That heart rate, blood pressure, oxygen saturation, chest pain at rest, urine output, or temperature. Which findings require immediate follow-up? I'll give you about 10 more seconds to answer this question. Awesome. So yes, we are worried about that blood pressure, the oxygen saturation, and definitely the fact that he's experiencing chest pain at rest. Awesome, Natalie, you are in the lead here today so far. Now, these are the things that we need to follow up with. Remember, we need to prioritize our ABCs in our patient. If our patient is alert, they're talking to me, and they're not experiencing any signs of airway compromise like stridor, then I can say, okay, their airway's probably good to go. But the breathing and circulation here, I'm a bit concerned about. Remember, the oxygen saturation was low, right? It was 89% on room air. And in a normal patient who does not have a history of COPD, we want that stat to be 95 or greater. Sometimes we will allow a 92 or greater, but 89 is definitely not good enough for any patient who does not have COPD. They're also experiencing a really high blood pressure and that chest pain at rest. And that can tell me that the patient's circulation might be compromised as well. Remember, if our patient's not getting enough blood flow to our heart, then they're going to experience chest pain. That's a circulation issue. So these issues must be treated immediately. Now, I'll give you guys another second to join in here. We're going to go to our next Slido question. Based on the current assessment findings and vital signs, what do you tell the provider that you suspect the client is experiencing? What do we think might be happening in this patient? An AFib with rapid ventricular response, COPD exacerbation, myocardial infarction, pericardial effusion. Okay, first we're thinking myocardial infarction. Second up is COPD exacerbation, and I'll tell you, MI is what we are worried about here. Now, Natalie, you are in the lead again. Awesome. Now, because this patient is experiencing chest pain, the number one diagnosis that we want to rule out is that myocardial infarction. Yes, the patient had that low O2 sat. And yes, that will happen with a COPD exacerbation. But remember about the primary complaint. You kind of have to put the whole picture together. You can't just focus in on one thing, because a low O2 sat can occur with a COPD exacerbation, but it also can occur with a myocardial infarction. And here the patient's primary complaint was the chest pain. That chest pain is what tells me the patient might be having a myocardial infarction. If the patient was experiencing, shortness of breath, and they were saying, I can't get any air into my lungs, I'm having a really hard time breathing, and let's say they were tripoding and their SATs were low, they were experiencing pursed lip breathing, maybe I would think more of a COPD picture, right? But you got to focus on the whole thing. You got to put it all together. Think about the symptoms they're coming in with. Look at their vital signs. And in this patient, Mr. Brown, we're thinking more so a myocardial infarction. Now, we don't have enough information to figure out whether this is exactly a myocardial infarction, but that's going to be our most likely diagnosis. Key things that tipped me off that this was an MI was that the patient was experiencing chest pain that was not relieved by rest. If that chest pain was relieved with rest, what would be the more likely diagnosis here? It's not listed here, just so you know. If the patient was having chest pain and it got a little bit better after resting, what would we think might be happening more so? I would think angina, right? Because angina is chronic stable angina. The patient is familiar with that pain. It gets relieved by rest. But here that patient is not having that pain relieved with rest, then I get more concerned about the patient. I'm definitely thinking more of an infarction picture. Now, this patient said he was having chest pain radiating to his left arm. No, that's a sign of cardiac pain. And know that there are also other signs of atypical MI pain. And that could include jaw pain, shoulder pain, maybe back pain. Those will also make you think that the patient might be having an MI, especially in some certain populations. Can you think about which populations would have these atypical signs of chest pain? Probably more patients who are older, they're elderly, or female. They can have those atypical signs of an MI, like jaw pain, shoulder pain, scapular pain, back pain. Indigestion also comes with that. So keep in mind all of those symptoms can tell you that the patient is having an potential MI. Now let's do our next Slido question here. Take a second for you all to join in. After discussing the case with the provider, which diagnostics tool do you expect to be done stat? A 12-lead ECG, an echocardiogram, a Doppler ultrasound to assess for blood clots in the extremities, or a CT scan of the abdomen or pelvis? Amazing. You guys got it. That 12-lead ECG is our #1 tool we need to be doing at this point. Natalie, you are smashing it. Great job. And Jen and Angelo, Sana, you guys are also doing really great. So, a lot of students don't really realize this, but when it comes to anybody complaining about chest pain, we need to prioritize that ECG. That's probably going to be our #1 priority outside of the ABC prioritization, of course. Now, the reason why we need to prioritize this ECG, because chest pain can be a bunch of different things, right? It could be an STEMI, it could be an NSTEMI, it could be angina. And in order for us to determine that, we need to do that ECG. That tells us what diagnosis our patient is presenting with. These 3 diagnoses are treated very differently. And so by doing this ECG, we can identify whether this patient is having a STEMI, whether they're having an NSTEMI, whether they're having angina, and it will dictate what the next hour will look like for the patient. Because of course, if the patient is having a STEMI, we are acting fast. We need to get this patient treated very quickly. If it's chronic stable angina, I have more time to work with. I don't need to work so fast. But the only way we know how worried we need to be about this patient is by doing that ECG. So you should always be prioritizing ECG for anybody complaining of chest pain. Now, how would you explain the process of getting an ECG to Mr. Brown? Take a minute to write a brief explanation, whether you want to type it on your phone or write it down yourself, and then we'll compare with what the nurse is saying here. Tell me what is it? What does an ECG entail? How do we do it? I'll give you another 30 seconds or so to write your explanation. Okay, Mr. Brown, since your primary symptom today is chest pain, we would like to get an ECG. By the way, ECG, EKG, those are all interchangeable names. Now, an ECG or an electrocardiogram will take a picture of the electrical rhythm of your heart from multiple different angles. In order to do this, I'm going to place stickers on your arms, legs, and chest and hook them up to wires attached to a machine. This will be done in just a couple of minutes and you will not feel any pain while it's being done. Do you have any questions? Tell me, how was your explanation compared to what the nurse said? So ECGs are a way for us to take a picture or video basically of the electrical movement of the heart. Because keep in mind, the heart has electrical capabilities and mechanical capabilities. In order for us to have the mechanical side of the heart function, we need to have that electrical side working properly. And so that ECG allows us to see how is the electrical impulses moving through the heart. Is that heart going to be able to pump correctly if their electricity is moving correctly? Now, ECGs are hard. I know they're hard. They're challenging, and it definitely takes some time to master. If you need help with ECGs, feel free to join a private tutor in a one-to-one session. They can spend the whole hour with you talking about ECGs and challenging your ECG knowledge. I also do small group sessions on ECG interpretation. They are a little bit cheaper than the private tutoring sessions at $25 an hour. And the next ECG session that I'm running will be on October 9th. So feel free to take a look at my small group schedule if you would like to join. Now, when we do our ECG for Mr. Brown here, we see this rhythm. Take a moment, take a look at it, gather your thoughts about it. Is this a normal rhythm? Is this abnormal? Is this what our heart should be looking like? What our ECG should be looking like? All right, let me know in Slido. What do you think about this heart rhythm? What does the ECG show? ST elevation, prolonged PR intervals, a normal ECG, or bradycardia? Amazing, guys. Yes, ST elevation. You saw how that that ECG tracing kind of looked like a tombstone. If you're seeing tombstones on your ECG, that's your sign that you should be worried about this patient. So we're seeing ST elevations on the ECG. I'm definitely going to be a bit more worried about the patient. Now, when we do this ECG, remember, we are looking at that ST segment when the patient complains of chest pain. And if we see that ST segment being elevated, then we're thinking our patient is having a STEMI. Now, I'll tell you what a STEMI is. You see our heart here. We talked about the blood flow through the heart. We talked about how the aorta here delivers oxygen-rich blood towards our body to perfuse our major organs like our liver, our kidneys, and to perfuse our cells so they can function properly, right? Now, the heart also needs its own blood supply, and it also comes from the aorta, and these are called the coronary arteries. These are the arteries that supply blood to the heart tissue itself. Fun fact, these guys actually get perfused in diastole, not in systole. Most of the time, arteries are getting blood flow, getting perfused, getting blood moving through them during systole. But for the coronary arteries, that occurs in diastole. Now we have a left coronary artery and the right coronary artery, and then they branch off a little bit more. But in a nutshell, these arteries can get damaged due to the presence of plaque. If our patient has a diagnosis of atherosclerosis, maybe they have hypertension, diabetes, high cholesterol, and smoking, all of those factors are going to increase the risk for damage to those coronary arteries and basically any vessel in our body in general. Things like hypertension, uncontrolled blood sugar, and smoking are so damaging to the inner lining of our vessels. They move through our body, it rips up the inner lining of vessels, causes damage along the way. And when that damage occurs, that's in a perfect place for plaque to build up. Now, when plaque builds up in our coronary arteries, you can see how the diameter of the blood flow changes from this to this. It gets really, really narrow, right? So blood is trying to flow through the coronary arteries to perfuse our tissues, and then it starts to experience this blockage, and they're like, oh boy, I can't move blood through that piece of plaque. When blood gets stuck, that creates a nice environment for a clot to form, and that even further decreases the amount of blood flow through those coronary arteries into our heart tissues. And so wherever that clot is being experienced, now those coronary arteries are not being able to perfuse with oxygen-rich blood, and the cells that those arteries are supposed to be serving will start to die. When we are experiencing necrosis or death of the heart tissue, of course, that's concerning. That is not going to be a good situation for our patients. We need our heart to function properly in order for our patient to survive. So if we're getting death of cardiac tissue, then it's a very, very big problem for our patient. Our patient's contractility is going to get compromised. The patient is going to have their cardiac output affected. So they might feel chest pain, shortness of breath, and dizziness. And then when we do that ECG, you will see that ST segment get elevated here. The ST segment is this portion of the ECG here. And if you see that way up high, then we are worried about an MI, okay? So this is telling me that the patient is having a STEMI. Now, if the patient was having an NSTEMI, what ECG findings might you see? It looks a little bit different. If the patient was having an NSTEMI, we might see inverted T waves. We might see ST depression instead. So if I were to draw this, you might see if we had an NSTEMI, you might see that ST segment all the way here. And then you might see that T wave get inverted. The difference between an NSTEMI and a STEMI is that a STEMI has full thickness of the heart wall being damaged versus an NSTEMI is only partial thickness of the heart wall being damaged. If the patient had chronic stable angina, they're still having chest pain, but there won't be any ECG changes, and there's not going to be any cell death happening. Okay, so that's the difference kind of between the three. So, as a nurse, you're receiving the following orders. We have an order for morphine, 2 to 4 milligrams IV PRN. Nitroglycerin, 0.4 milligrams PRN times 3 for the chest pain to be dissolved under the client's tongue. Supplemental oxygen via nasal cannula to achieve an O2 sat greater than 90. Draw a serum lab test, specifically a troponin level, and administer aspirin 325 milligrams non-EC. So not that baby aspirin. Which orders does the nurse recognize as essential and implement immediately? Select all that apply. Which one of these orders is essential? And when we say essential, we're thinking, which one is our priority? Which one do we have to do? Okay. We got mixed results here. Our correct answers here are nitroglycerin, oxygen, that troponin level, and aspirin. Morphine is the one that we don't necessarily need to be prioritizing at this point. Awesome job, Natalie. Oh, Bing, you're coming up on the leaderboard here. Great job. So Here we need to prioritize nitro, oxygen, a troponin level, and aspirin. Now, nitroglycerin, remember that is the medication that we use to treat angina, but also can be used to treat an MI. We can administer 3 doses whenever the patient is experiencing chest pain, as long as their blood pressure is okay. And it helps us vasodilate those coronary arteries, and if we vasodilate them, hopefully we can get more blood flow through them. And as well, it can lower the workload on the heart by reducing the blood pressure. Now we will give the patient oxygen, of course, because those sats were 89%, we want to optimize their oxygenation levels, because the more oxygen to the patient, the more oxygen to their tissues. We are definitely interested in that troponin level. For any patients complaining of chest pain, you're prioritizing an ECG and then a troponin level. This troponin is an enzyme in the heart that is specific to cardiac tissue. Now, this enzyme helps our heart contract and have those muscular movements. But if our heart cells are dying, they experience apoptosis. Those cells will basically explode, and all of the contents of the cells will get released into our bloodstream. So when we check our patients' labs, we'll be able to detect troponin level if our patients are experiencing cell death. So an elevated troponin level tells me cell death is happening, and that tells me we're working with an MI here, a myocardial infarction. Whether it's a STEMI or an NSTEMI depends on the patient's ECG. We're also going to administer aspirin for this patient. Sometimes we give 160, sometimes you can give up to 325. Either way, this patient needs an antiplatelet medication. Now, aspirin is not an anticoagulant, it is an antiplatelet. Remember, platelets are used to clump together to form clots. Now, if our patient is having a blockage because of a clot, aspirin is going to help prevent this clot from getting any bigger. So it is definitely important for us to administer in our patients complaining of chest pain. Morphine is not as important because we could reduce the workload of the heart and reduce the pain by giving nitroglycerin first. And then if the nitroglycerin is not working well enough, then we might consider proceeding to morphine. Okay. Now, let's reassess our client after these interventions while we wait for the labs to resolve. We have that heart rate of 90 now. The blood pressure is 132 over 64. We have oxygen saturations of 96% on 2 liters of nasal cannula. The respiratory rate is 20, and the temperature is 37.6 Celsius. How do you think the patient is doing now? Have they improved? Have they not improved? How are they feeling? Whenever you intervene and do stuff with the patient, you should always circle back and assess the effectiveness of your interventions. So here I would say, yeah, the patient is probably doing better. Yeah, they've improved, exactly. So let's chat with Mr. Brown here. After taking the nitroglycerin tablet, how is your chest pain feeling? By the way, guys, how do we administer nitroglycerin? Do we swallow it? Is it IV? It's given under the tongue, right? It can be either a tablet form or a spray form, and it's always given sublingually because that's the fastest way we're going to get it to work. He says, my pain has improved. It's a 3 out of 10 now. I'm also feeling less anxious. Since I'm able to give you the nitroglycerin every 5 minutes for chest pain, I will give you another dose to see if we can get that pain to go away completely. Okay, sounds great. I'm sure he's happy to be relieved of his pain. Now, whereas we're waiting for that pain medication to work, as we are waiting for the results, oh, the labs have resulted. Here are a list of labs. It looks like we did complete blood count, we did a CMP, we checked his troponin levels, and we did a lipid panel as well. The red are highlighted things that are abnormal here. take note of what you think is abnormal. Thankfully, for the next-gen NCLEX, we are getting normal lab values given to us. So here we're seeing a hemoglobin and platelet level being low. The glucose is high, troponin is high, and these lipids are all out of whack. Now, while we don't need to know normal levels for our labs for the next-gen NCLEX, you definitely need to be able to interpret them. You need to know what all of these mean. If the patient's high or low in any of these labs, what does that mean for our patients? Now, tell me on Slido, of those results, which are the priority to report to the provider? Select all that apply. Which labs are a priority for us to communicate with the provider? Ooh, yeah, great job, guys. Troponin and the lipid panel are definitely going to need to be addressed at this point in time. Those of you who said glucose, it's a good thought. Yes, glucose was elevated, but in times of stress, our patient's blood sugar level will be elevated, right? Cortisol will be increased, and that is kind of expected. As long as the patient's not in DKA, we're not too worried about that the blood sugar being too high at this point. But we definitely need to worry about that troponin level. That tells us there's going to be some infarction happening in our patients. There is death of the cardiac cell, and we need to be suspicious, and that pretty much confirms that our patient is having an MI. Now, this lipid panel is also concerning because remember how that patient was not on any medications to reduce cholesterol levels? We might want to add something here because if the patient proceeds to go without medication, then the patient will be at increased risk for developing another MI in the future. Now, although the hemoglobin level was low, the glucose level was high, and the platelets were low, again, they're not critical at this time and does not require immediate intervention. If our patient was experiencing an elevated lipid level and they have a history of high cholesterol, what's the ending for those medications to reduce cholesterol levels? What do those medications end with? Those are statins, right? Those are things like atorvastatin, rosuvastatin. Those will all work to reduce our cholesterol levels and reduce plaque buildup in our blood. Great. So, after discussing the ECG, troponin, and the client's overall presentation to the provider, a plan is made to immediately transfer the patient to the coronary cath lab for assessment of the coronary arteries. Now, during this assessment, it is likely that the provider in the cath lab will find a severely occluded coronary artery due to those ECG and troponin levels. Therefore, we can expect a percutaneous coronary intervention, or a PCI, to take place during this procedure. This is where a catheter is introduced into a peripheral artery. Typically, it's going to be the radial artery. I have seen interventionalists go through the femoral artery. And a stent is placed in the affected coronary artery to restore blood flow. If the stent is unable to be deployed, the client may require a coronary artery bypass graft, which is a form of open heart surgery. You and the provider can enter the client's room to explain this process to the patient. Remember, the standard of care is door to PCI in 90 minutes, and this is a universal goal for any clients experiencing an MI. So once we've determined that the patient has an MI, think about how we do that. Remember, ECG, positive troponin. Really, we can diagnose it based on an ECG. Our number one priority really is to, once we see those ST elevations on the ECG, is to get the patient to the cath lab as soon as possible. And this should be done within 90 minutes of the patient presenting with their chest pain. And when the patient undergoes a PCI, when they go to the cath lab, The physician will enter the patient's vasculature either by the radial artery or the femoral artery and snake a wire all throughout the patient's vasculature to get into the coronary arteries. They use contrast to visualize the coronary arteries to be able to visualize blood flow through those arteries, and you'll be able to tell which vessel is blocked. Now, once they find the diseased vessel, they're going to take that wire and inflate a balloon. This balloon will push the plaque to the side to reestablish patency of that blood vessel, and then they're going to leave a mesh stent in to make sure that that vessel stays patent. Make sure that plaque doesn't continue to occlude that vessel again. Okay, so that's what's done in the PCI. Now, sometimes if the patient's vessel disease or the plaque buildup is in a place that's not accessible, or maybe there's just too many places that are obstructed with plaque, then the patient might have to undergo a more serious intervention called a CABG, coronary artery bypass graft. When the patient undergoes a CABG, it is an open heart surgery. They're going to have to do a sternotomy to open up the heart. It is definitely more invasive and has an increased risk of infection. Okay, so that's if the patient has a really diseased coronary vessel, they have a huge plaque burden, or the vessel is too hard to get to. Now, after their MI, we're going to teach our patients to, stop smoking. Remember, smoking is really, really damaging to the inner lining of the vessels. We're going to teach our patients to consume a heart-healthy diet. So that's a diet with low fat, low salt, low cholesterol. Remember, we want to try to reduce those cholesterol levels because the globs of fat going around in our bloodstream is what helps make those plaque build up. Salt will help us retain water, and that will elevate our blood pressure. We don't want to do that because, remember, increased blood pressure is very damaging to our vessels. We're going to teach our patients to do aerobic exercises. So things like swimming, hiking, biking are all really, really good for the heart. It's going to teach the heart to work more efficiently. And then after the PCI, there's some things we need to teach our patients specifically. So there's going to be some medications that these patients are going to be put on after their heart attack. That will include a beta blocker to reduce the workload of the heart. And they're going to be on 2 antiplatelets like aspirin and another antiplatelet. Usually it's clopidogrel. We add in this antiplatelet therapy because that mesh stent in the coronary arteries is a lovely environment for clots to get stuck in. So it's really important that the patient ends up getting or taking and being compliant with their antiplatelets. Otherwise, I've seen it, they get a heart attack within their stent, and that stent that gets diseased again is really, really hard to work with. And then we're going to prescribe a statin for this patient again to reduce those cholesterol levels. After the patient has a PCI done, they're going to have an access site. Typically they're radial, sometimes they're femoral. And remember, it's an artery, so it experiences a lot of perfusion. It has high amounts of pressure in those vessels. And so it's important for us to limit movement of that affected extremity for, at least an hour, but up to 12 hours. Make sure we're looking at the site and assessing for bleeding and pain, and assessing distally to make sure that the color, sensation, and movement is intact. We need to notify the healthcare provider if there's any bleeding or any neurovascular compromise to the site. All right, guys, that was the end of our cardiac case study. How'd you guys feel about it? Was it good? Did you guys get it? Did you understand how we work with an MI? If you guys are interested in learning more with Archer Review and you need a little bit more practice, feel free to sign up for our SurePass combo. That includes our live review, which is happening at the beginning of October. It includes more than 2,000 questions on our QBank, and it also includes any on-demand videos. Now, if you don't have the capacity to join in with our SurePass combo, there's always an opportunity to join us through small group sessions. Now, when you go through archerreview.com, you can click these 3 lines and find our private tutors under the NCLEX tab. And you scroll down and you can see all of the tutors that we have with Archer Review. There's Lexi there and Lauren, Rachel, and then there's me. Now I want to show you how to book a small group session. So I do small group tutoring here. And if you do more than 3 sessions, you get a bit of a discount here. And then you can choose time plus slots and you can see my calendar, what I have left. Later on today, if you guys are free later on, you want to work with me some more, we're going to be doing the 2-hour NCLEX review. You can just sign up for 1 hour if you're interested, and then sign up for the second if you're still interested. And then we're doing prioritization questions later on today. Tomorrow night, I'm doing pharmacology memory tricks. So if you're having troubles with pharm, definitely check out that session because I provide tons and tons of tricks when it comes to pharm, and it will help you remember pharm for the NCLEX. Any other questions that you might have here, you can feel free to put them in on Slido and I will help you answer them. Awesome. And otherwise, thank you so much for joining me today. I hope you enjoyed it. I hope I'll see you soon. And good luck on the NCLEX for anybody who is testing soon. I'm just going to go through these questions and see if there's anything that is outstanding. Why was morphine not administered? Remember, we're going to administer nitroglycerin first and then opt for the opioid analgesia. Lots of good answers to the questions here. Would congenital heart defects be diagnosed on an echocardiogram? Yeah, usually those are pretty well diagnosed on ultrasound in conjunction with the client's condition and presentation. The first med to give is nitroglycerin. When we're suspecting an MI, probably going to opt for nitroglycerin as long as that blood pressure is okay. But I would probably prioritize oxygen in that patient who was hypoxic. So oxygen first, remember that is a medication, and then I would consider giving the nitroglycerin and the aspirin afterwards. If we had an anticoagulant there, it would be a priority too. Yes, aspirin is our go-to when it comes to any MIs. That is the medication that's going to work the fastest in helping treat that coronary blockage. Great. Awesome. Well, thank you everybody for joining us today for a free webinar Wednesday. Hopefully we'll see you guys again soon. Reach out to any of our tutors or our support team at Archer if you are interested in any other Archer products. Take care and have a great rest of your day.